Here, and this is the Advanced EMT Medical Assessment Skill Station. And without further ado, I'll get us started. So, in this scenario, you show up at the station at 6 a.m. for a 12-hour shift, and 15 minutes later, at 6:15, you get a call. And for the call, it says that there is a 45-year-old woman in respiratory distress that is in need of some help. And you get in your ambulance, turn it on, start going. On your way there, you're kind of thinking about the things you'll need. So I definitely want to bring in the jump kit, and I definitely want to bring in the O2 tank. So with that in mind, we show up on the scene, and as we're parking the ambulance, I like to back it in so we can just drive straight to the hospital without having to turn around with a patient in the back. And after we do that, the patient actually meets us at the door. And at this point, I see that we have one patient. That's the number of patients, but even before I get out of the ambulance, I have my PPE on, make sure the scene is safe. And we also can consider COVID risk, so from a distance, like, have you been out of the state, have you been in contact with anyone with COVID, put a mask on, things of that nature. And at that point, give my general impression of the patient. General impression of the patient is that they have shortness of breath and that they are in need of some respiratory care of some kind. And I would also consider manual stabilization of the spine with C-collar, but there's no indication, and I was never told by dispatch that it was a trauma injury of any kind, a trauma. And so that isn't needed in my opinion. And then I would also consider additional ALS help, but at this point I don't think it's needed either. So I want to go right into ABCs, and before I actually do that though, because they're just staying at the doorway, you want to sit the patient down. And because we backed in our ambulance so nicely close to the door, we were ready to go, we just walked them right from the door into the ambulance. It's closer to go to the ambulance than walking back inside the house, and then you just gotta make up all that ground. So the smart thing to do if they can walk to the door is just assist them down a couple steps and get them to the ambulance. And at this point, you want to assess the airway. The airway is open and good. Breathing is really fast. She's tachypnic, and it's really shallow. So really shallow, rapid breathing. And when she's talking, it's only 1 to 2 words at a time before she's out of breath. So you observe that. And also part of my breathing assessment, I really want to listen to her lungs, because it's just good to listen or touch the part that is injured on a patient, because in this situation her lungs are injured. We'll be doing her lungs. So auscultating the lungs, deep breath in and out. Great. On the sides as well, in, out, deep breath, good, in, out. And at this point I could also instruct my fellow EMT to start taking vitals. More on the back here. When I listen to the breath sounds, I hear wheezing bilaterally. So that is an indication of respiratory distress. And after my EMT takes blood pressure, I get a reading of 96/73. Also want to finish my ABCs with circulation. Feel a really strong bounding pulse. And count a rate of 120. I also get word back that The SpO2 is 83, and that's very low. So immediately after hearing that, I want to apply oxygenation therapy. So I'm going to attach my non-rebreather mask to the patient and use high flow oxygen, at least 10 liters per minute, I would say, to get that going. And then we can start transporting to the hospital. I would like to load and go on this patient just because they're in so much distress rather than stay and play with the patient. On the way to the hospital, start our sample assessment, and as we're doing that, we can make sure there's no signs of trauma or blood. There wasn't really any indicated, but we can still check, ask them about it. Ask them about any allergies. No allergies. Ask them about their medications they take. She takes albuterol and also takes Lasix, I believe it's called, and that is for treating edema, fluid in the body that's not needed, caused from things like congestive heart failure or liver disease. Past medical history, respiratory distress is that she has COPD, emphysema from years of smoking. The last oral intake was last night when she had dinner. Events leading up to this, she was just cleaning in her attic. It was kind of dusty, and she got overwhelmed from all the pathogens in the air, all the dust, and she decided to go downstairs to get out of that environment. And she went downstairs, things actually got worse rather than better, and that is when she decided to call us. And from there I can go into my OPQRST assessment, talk about when it first started. She says that it's been going on for a few days, but this is when it really got worse. Ask her if she can describe the pain, and she said it's not really painful per se, but very, very uncomfortable. And I asked her, does it radiate anywhere? No, just kind of in her chest. And severity, she says it's like a 5 out of 10 on the pain scale. And the time it occurred was this morning around 5:30, right before she called. And at this point, I want to take another set of vitals. About one every 5 minutes right now. And so have the Zoll, SpO2 on her finger, put the blood pressure cuff on her, let it do its work, comes back. The blood pressure is the same, and the respiratory rate has gone up a little bit, and it was about 34 when we first got here, now it's about 40. She's really breathing kind of rapidly, which is not what I want to see. And her pulse is about the same at 120. And SpO2 has gone up a little bit to about 85. But because she's still breathing at a faster rate, I think another intervention is needed. At this point, I would consider using an albuterol nebulizer because the patient is used to albuterol, and also because they don't have any allergies to it, and they have a high breathing rate. So at this point, get my nebulizer out. Great. And I'm gonna put 2.5 milligrams of albuterol in it. to the high flow oxygen. You know, 10 meters per minute, about the same again. Take this off. Switch as soon as possible. Great. That's good. At this point, I would also consider starting an IV and want to be taking vitals again every 5 minutes. Now that intervention has started, could see if maybe they want to sit up more, maybe that makes them more comfortable breathing. You want to also be considering a BVM, although bagging someone who's ANO ×3, like this woman is kind of difficult. So before I did that, I would definitely try to just coach her and say, you really focus on taking deep breaths in, you know, letting them out, trying to lower the respiratory rate. And you can also monitor this by attaching, you know, to the capnography and or nebulizer to capnography, seeing, you know, if you do decide to do the BVM, you will have a lower reading on your capnography report than if you were squeezing too fast, you know. So that is another way you could monitor her breathing. And at this point, just rapidly transport to the hospital and call in and tell them, you know, my impression of the patient is that she has shortness of breath, has COPD, history of COPD, and that her pulse is 120, SpO2 now has gone to 88, was it 83 to 85 to 88 now, so it's trending in the right direction. Her respiratory rate is going up and down, and with coaching it has gone back down from 40 back down to around 30. So respiratory rate from 34 to 40, and then we've got through that to 30, so BVM wasn't needed. And that we will be showing up at the hospital very shortly. And yeah, when we get to the hospital, help the patient off the stretcher over to the new stretcher and give my report to the nurse there. And at that point, the treatment will be complete. Okay, thank you.